So we are going to discuss about radiation dermatitis. Dr. Dipanjali has shown us what was discussed in the recent consensus meeting, and Dr. Ajay has also shown us what are the treatments that we give for patients who have this radiation-induced dermatitis. What we are going to discuss today with our panelists is basically how we practice those guidelines in the day-to-day practice, how we implement those guidelines in the day-to-day practice. So, the first question that I wanted to ask to my panelists is it a problem in the real world scenario? Do we actually see those many radiation dermatitis? What nowadays, what we used to see with the cobalt era? Dr. Kamal?
Yes. Since we have shifted to IMRT and IGRT, we see them very less often. But occasionally, we do come across, especially with head and neck cancer patients, who have significant weight loss, somewhere to the tune of more than 10%. About
Mhm.
maybe 50 to 70% of the patient do land up in such a situation. And in breast cancer, when
So,
we use a bolus, then we see it. Or when we are treating vulva, we can't treat vulva without landing up into this situation. Thank
agreed, sir. Uh, Dr. Gautam, anything else you want to add? So, sir, it said about head neck, breast with bolus or chest wall with bolus, and then vulva. Any other site where we see radiation dermatitis more commonly?
So I choose to disagree with Dr. Kamal because primarily I treat, Bhopal is considered the capital of head and neck cancers in India, probably in the world.
Mhm.
And most of our patients are locally advanced, wherein we'll have to use a lot of bolus and other dose building materials. So for me, this looks like a real world thing to me. We come across these situations very often. Well, so that depends upon where this you are engaged into. But otherwise, hi Bhushan. So this to me is a routine day-to-day work.
So, the next question that I'm going to ask to Dr. Gautam only. Sir, you have said it's a day-to-day routine occurrence that you see in your OPD. What is the incidence of
Yes.
radiation-induced dermatitis when we compare acute versus no, when we compare mild versus severe?
Excuse me, Bhavin. Just a minute. Let me use my headphones. You're not audible properly. Just
So, in meanwhile, let me pass on this question to Dr. Bhushan. Bhushan sir.
Yes, Bhavin. So basically, as Dr. Kamal Verma and Dr. Gautam sir were discussing, we have all moved from our conventional radiation to high precision radiation with the help of all the technologies that we all have. And we have certainly seen this kind of a side effect incidence going down. Still, it is there because of inherent radiosensitivity, which we cannot really control. But the incidence of severe dermatitis has gone significantly down, no doubt about it. Yes, if you talk about mild dermatitis, every patient is going to have mild dermatitis, like a grade 1 reactions. Yes, you cannot avoid. But certainly, severe dermatitis incidence has gone down, and I would say around 10 to 20%. I would say around 10% patient probably get severe radiation-induced dermatitis. I don't see I don't appreciate more than 10% patients getting severe dermatitis. Not talking about mild or moderate. Every patient is going to have mild to moderate dermatitis. Talking about head and neck, say breast, even I would
Well,
say breast
Bhushan,
zone more. Pardon? Yes, boss.
I think anything more than 10% is fairly good amount of reaction. It's not rare, especially
But
if
the
you
incidence
happen to
has
come
come down.
across grade for.
Suppose if you see earlier days, we used to like 30 or say 40% patient getting into that kind of a grade. Now it is around 10 to 15% is certainly a good thing. And in breast, we
Hmm,
practice hypofractionation. Well, last day of radiation is just a mild erythema or say grade 1 or grade 1.5 kind of a reaction. And yes, after say
correct,
few days, we get into
correct.
2.5. But grade 3 is no more seen in a breast radiation nowadays with the hypofractionation.
So, Dr. Bhushan, let me stop
Correct.
you here and let me ask this question to Dr. Revti. She is a breast radiation oncologist, breast consultant at Tata. So, Dr. Revti, do you have any, your opinion is same as what Dr. Bhushan has said, or you want to add anything?
I would agree that the rate of grade 3, grade 4 is very low. It's probably as low as 7%, surely not 10%. The rate of grade 1, I would place at around 80%. Almost all patients do get at least grade 1. Grade 2, again, is probably around 20%. So, yes, surely the rate has decreased. And also, we other than the technique which has changed, we're also more careful during simulation, I would say. Are there folds? Does the patient need revision of flaps? We also do things like, if there are folds, we contour them and ask to restrict doses to the folds. So because of all these techniques and being very hands-on at the time of simulation as well, I think we see almost no grade 3 skin reactions, and we do not use all fits, obviously.
So, Dr. Gautam, the other thing that what we wanted to know, if
Hmm.
a patient has an acute radiation dermatitis, we every time we keep on telling patient, we reassuring patient कि कुछ नहीं ठीक हो जाएगा treatment खत्म होने के बाद में. But does it have any negative impact on the patient or the treatment per se?
Bhavin, maybe grade one, I would be hanging between yes and no, but grade two onwards, definitely yes. It does have clinical impact, and it also has a great social impact. Especially if a patient has poor hygiene, on top of that he has dermatitis, and that leads to, there are chances of secondary infection, and then some, you don't want a smelly somebody to go around someone, so that definitely has some impact. Grade 1, I'm not sure, maybe this mild erythema, and that looks like a kind of he had just returned from Goa or somewhere in a tropical place.
I remember, I don't
And
know who, but yeah. Sorry, sir, please continue.
no, that's all right, you can go ahead. Yeah.
Someone, sir, wanted to share something.
Yes, Bhavin, you are right that people do remember grade 2, grade 3, and grade 4s throughout their life sometimes. And another thing was our first speaker told that there are different mechanisms for acute and chronic dermatitis. Now, chronic dermatitis goes for longer period as compared to acute, and it looked like they have different mechanisms. But actually, what I found in my practice is that they are linked to each other. More is the severity of acute, more will be severity of chronic, and then the patient will remember us throughout the life. So it is always useful to reduce the severity by any means, even for acute radiation dermatitis, so that patient can forgive us easily. Thank you.
In fact, I would like to share a small anecdote that one of my senior when I was working in Tata used to tell patient कि अरे सर डर्मेटाइटिस मतलब स्किन काला नहीं हुआ तो पता कैसे चलेगा ट्रीटमेंट हो रहा है कि नहीं हो रहा है. But this is what we used to tell patient to reassure them कि it's a temporary thing and that means your treatment is working. But yes, severe dermatitis, someone who has got severe dermatitis, grade 3, grade 4, someone who has a discoloration post treatment also will always remember that this is because of the radiation. And Dr. ABC was my radiation oncologist who has given me this scar. So this is what we have already discussed. As everyone has said, the average risk of severe changes, the dermatitis incidence approximately varies from 5% to approximately 20-25%. Highest being, as the previous presenter has also said, that highest being in the vulval cancer or the anal canal cancer. I wanted to ask, so if a patient with a breast cancer or a vulval cancer or head neck cancer or a anal canal cancer, do you intentionally give inform patient that there is a possibility of treatment break due to dermatitis? So, Dr. Kamal,
Yes, we have to reassure them from beforehand. It should not come as a surprise to our patient. Although we also quote along with this line that the incidence is very less. It's less than 10%, so we don't expect, but it should not be a surprise. That helps us in our practice and having comfort, being comfortable with the patient, getting his confidence, and continuing with treatment.
So, Dr. Gautam, anything different that you do? Dr. Gautam, Dr. Revti?
Yeah, so patient counseling is obviously the most important part. And more than informing them about the possibility, it's extremely important to tell them what is the care they need to take, what are the precautions they need to take, and obviously that is the first step. If they do not comply to those instructions, then everything else is sort of expected. So yes, patient counseling is the most important prior to radiation, making them aware of what are the changes they may notice and what is it that they need to report to us, and frequent reviews during treatment. Maybe some patients need more frequent reviews.
So, Dr. Bhushan, what are the scales or tools that we use routinely to describe radiation dermatitis?
Basically, what it's kind of a, yes, we do have this RTOG and CPCAE tools and all, but it's more of a personal experience with this kind of a situation that we generally explain patient that this is like grade 1, this is like grade 2, this is like grade 3, just to make them understand a little bit rather than going into the technical jargon, because this is for us basically, not for patient. For patient to understand severity, just थोड़ा सा रेडिश होगा या थोड़ा सेंसिटिव होगा, स्किन थोड़ा ड्राई लगेगा आपको, अगर मॉइस्ट होता है तो इट्स नॉट करेक्ट, यू हैव टू कीप इट ड्राई. दैट काइंड ऑफ अ jargon which patient would understand more is more important than the technical one which we note in our day-to-day notes. That's fine, but as we were just discussing in the previous question, I had a different angle to it. See, we all explain about the radiation dermatitis. It is a timely manner. It's like a dose dependent and time dependent phenomena, which we can explain the first week, second week, third week. This is a likelihood of reaction that may happen, and this is the way you should take care of the situation. But even if you think that as a vulva would get more reaction or anal canal, but I still feel that is more of a APPA field arrangement or a 4-field box arrangement that could give rise to that kind of a reaction. Nowadays, I don't remember a CA vulva or CA anal canal giving a treatment break because of dermatitis. I really don't remember. And even if that happens, that is in the last leg of radiation, where 2-3 days left, we just finish it off and then take care of the reaction, rather than giving a break to heal those reactions and then again calling patient for the 3 or 4 radiations. So I don't see giving a break unless and until there is a very unusual situation in between. There are so many reactions that a break is needed, and then again 50% of radiation is remaining. I think that is more of an intrinsic radiosensitivity than the timely mannered radiation dermatitis. That's my opinion.
Great. But as you have said, the guidelines what we usually follow, RTOG and CPCAE, those are physician reported outcome guidelines.
Right.
Don't you think that we should have something where patient would also be able to tell us कि last week से ये हफ्ते में मुझे अच्छा है, बुरा है, ज़्यादा अच्छा है, right? So it should be a combination of both.
I don't know what it is. Comes from HRD extract, no? Called you and said.
Sarvan is. Acha. Okay.
So this is what I wanted to have a small discussion. So I want every one of us to grade what grade it is, because this RTOG grading I have realized, and it has been documented also, it is very subjective. So this first one, everyone would agree that this is a grade 1 reaction.
Yes,
Anyone has got a different opinion? What about this second one and this third one, Dr. Bhushan?
yeah, I would rate it's like a grade 2, and this is both grade 3. I would say just 3 more
Grade
than 3.
2
It's
and
like
grade 3.
ulceration is there, so ulceration is like grade 4.
Okay. So 1, 2, 3, 4. Dr. Revti?
Yeah, similar. But I also need to see it in person more than photograph.
Yeah,
I
definitely.
know, but this is the
Yeah, but yeah,
So,
overall,
Dr.
yes.
Gautam sir and Kamal sir.
Yes, the one is just erythema. Second one shows some patches of dry desquamation. Third one is also dry, but fourth one looks wet. I usually follow these things: grade one, two, two, and 3.
Mm, Gautam sir is there. Gautam sir.
No,
Not
he's
audible,
not.
sir. Not audible.
No, he's probably logged off. Some internet connection issues.
He is there, but he's on
Not
mute.
visible in the list.
Uh,
Just a moment. Am I audible now?
Yes.
yes,
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 Yeah.
sir.
yes.
Okay. Okay. So to me, it looks like one, two, four for sure. The third one, I am confused between two and three. I'm not sure. Maybe I need to have a closer look. But yes, two
So that
would
is
be.
the problem. That is the problem because whatever scales that we are using, the ideally it should provide a common language for the description so that we can guide and collaborate. We can
Correct.
form a management
Correct.
guideline. But these are the cons of this scale. So it is subjective. It does not account for the variation in various things, including skin color. And the what we have discussed right now is does not account for the patient reported symptoms. So, any apart from these two scales, any other scale that we use, as Bhushan sir had said that he used his own scale to simplify this for the patient कि थोड़ा सा irritation होगा या फिर sensitivity होगा, red होगा, black होगा. But apart from this, there are any other scientific tools that we use.
Uh, I'm not sure. Probably there's a tool known as RISRAS tool, which takes into account the patient reported outcomes. I honestly do not use that. There are two, three other tools as well about which I do not remember, frankly.
No, because there's a quality of life dermat questionnaires also, but
Yes,
I
correct.
don't know in Tata also and outside Tata also. I have not seen anyone using it. Probably someone is even if someone is using, then probably under some trial setting. So this is what we have discussed previously. The difference between clinician and patient reported symptoms. So do you agree with this finding, uh, Kamal sir?
Yes. You see, this classification system is mainly subjective. There is not much objectivity to it. One of In our one of discussions, we were bothering how do you define patchy and confluent. Same thing may look patchy to somebody, and another fellow will take it as confluent. So in itself, this is all a confusion. So that is why I simply follow it is erythema, dry desquamation, and wet desquamation. That's all. That because management will depend on these things, how to manage.
Agree. Agree. Dr. Reti,
I
so
agree with
any
Dr.
opinion
Verma.
on this?
I agree with Dr. Verma. I think the grade scale, the grade is mostly for research. When you're reporting something, you need to know grade one, grade two. But in everyday practice, it's more about what you see. Can you see redness? Can you see, folliculitis? Can you see desquamation? Does the patient feel pain? And largely, your management depends on what you see and what the patient tells you, more than you don't say no, this is not grade 3 yet and I won't intervene now, things like that. So it's more about what you see in clinical practice. It's more of a spectrum. I feel you don't really place it very sacrosanct into grades, but for research obviously it's important to grade it.
So now we'll come to the risk factors. I think most of the risk factors were previously covered, but I want
Yes.
one of you to enumerate what are the risk factors. So let's start with Bhushan sir. Patient related, treatment related.
Yes, yes. So if we talk about patient-related risk factors, is site, volume of radiation. More skin fold, more will be radiation reactions, and skin fold are related to obesity most commonly. maybe because of some other anatomical variation, the skin folds can be more. But it's most generally obesity. Age, I really don't agree. Somehow I feel older age group they may tolerate radiation better. I don't know why, but it's my thing. Age, I really don't think should be the factor personally. Smoking, yes, but we cannot really differentiate between a smoker getting more reaction and non-smoker getting less reaction. So that's again we don't document that. And surgical reconstruction surgery, if the reconstruction surgery is creating kind of a anatomical change which is leading to a more of a fold kind of a situation, then yes. But in general, reconstruction surgery should not be a additional risk factor for radiation dermatitis.
Bhusan,
So I
I would
would,
like to add, can I? Yeah.
Yes, yes.
please.
So I would like to say that an improperly done reconstruction surgery, which is creating some kind of fold and bolus effect, probably has. Otherwise, a nicely done
Otherwise, nicely
reconstruction
done,
surgery. Yes.
kind of a flap which has already been kind of accepted flap will not give us any issues in radiation.
Because there are two things. One, either it is creating some kind of dose building effect. Another one, it is interfering with the blood supply somewhere. So that is the two reasons why reconstruction surgery might lead to enhanced reactions. Yeah.
So I would like to put this question in a different perspective. So let me ask Dr. Revdi first that she treats a lot of patients who had undergone a breast reconstruction. So, what is her opinion with respect to breast reconstruction? And then I would ask Dr. Kamal, what is his opinion with respect to head and neck reconstruction? Because we should not take reconstructive surgery as a one chunk, and then I would think that breast reconstruction patient would behave differently, and the head neck reconstruction patient would behave differently. So, Dr. Revti,
Yeah, so first of all, it depends on what kind of reconstruction. Is it chest wall, is it a post mastectomy reconstruction? In which case, I think all our patients go in a trial. We have an ongoing trial where we are comparing two dose fractionations. So all of them go in the trial. So that itself ensures quality of care for all the reconstruction patients. And if it is just an oncoplasty or if it is a flap reconstruction, then again, we make sure, so we don't treat the whole flap to begin with. So we contour, we have certain, in-house contouring techniques so that we don't, we treat the minimum volume, especially the boost volume, we restrict so that we don't cause too much skin reactions. So it's mainly about technique there, contouring technique. We involve the surgeon in the planning too. We ask them to come and to show us where exactly, what kind of transposition was done, where the tumor bed was, where do they want us to give the boost instead of treating the whole flap. So minor things we follow, which which gives rise to a good dosimetry and less skin side effects.
Kamal sir.
Yes, head and neck cancer is a bit more unique regarding dermatitis after reconstruction. I have seen actually the things happen. What I found was the major risk factor, one which you can predict, is weight loss. More is the weight loss, more are going to be reactions. Somehow they are etiologically related, and somehow when the mass or the cast loosens up. Now, this reconstruction creates a problem in loosening up because in breast, maybe sometimes we take radiation, maybe 3 months later, 4 months later. By that time, it's all settled in. But in head and neck, we usually take them post operatively within maybe up to 6 weeks, 8 weeks. At that time, the graft is still being accepted at the recipient site and it changes its shape, size, and the contouring. And if that gives a gap in the cast, these patients do develop reactions. So in such cases, especially in the patients who get a graft from a distant site like PMMC, but local rotation flaps, I found them comfortable enough. They don't create much problem except for some small remodeling, and that doesn't cause much issues. But bigger flaps with excessive weight loss, with remolding, we do expect some amount of mucositis to go and dermatitis to be enhanced. But overall, I have seen the graft in itself hasn't caused much problem. More problem is the associated weight loss. If patient cannot maintain nutrition and hydration, we are in a problem with the graft or without the graft.
So there are few things that I want to point out because we are already running late. So, how we should deal with the radiation dermatitis? The one thing that I want anyone to take this question. Role of pre-planning. That is the question number one, and the other question is treatment technique. So we will talk on that, and then I will conclude my session. So, Dr. Gautam, role of pre-planning.
Yeah.
What specific things that you see in pre-planning?
Okay. So, as you rightly said, number one, let me recapitulate, Bhavin, that we have already discussed that these grades are not watertight, right? Number two, come back to skin basics. If your skin is dry, you have something, you're dealing with a dry skin disease, you make it wet, you moisturize it. If the skin is weeping, you try to keep it dry. For me, the pre-planning is number one, as you have already written, that hypersensitivity syndrome, we cannot do anything about that, actually. Number two, smoking, yes, we do counseling for the patients to stop smoking so that the chance of dermatitis becomes less. Previous medications, well, there are certain things that are mandatory. I do not know. Rather, I would be more worried about the radiation recall. Probably we are not going to discuss that. Uh, Maintaining a good hygiene, washing with non-alkaline soap, and keeping the area well pat up and dry. So that is more important. And for me, for most of the patient, we start using low potency corticosteroid right from day one. And probably that is one single biggest factor that prevents the upliftment of grading, rather from going from 1 to 2. And up to 2 is acceptable, and that is inevitable. But arresting it at level 2 is the single most important thing that keeps patient very comfortable. If they go to grade 3 and 4, that becomes very difficult to deal with.
So, Dr. Bhushan, anything specific that we should do in the radiation planning technique?
Yes, if you talk about breast, more and more, so I'll just differentiate between breast and head and neck. So first I talk about breast. As Revati rightly said, we can avoid folds. So a patient has got a bulky breast where we can, in a counseling time only, we can see it's going to have a kind of a more reaction because a kind of exaggerated inframembrane fold. So in that case, probably instead of using a slope board, we can have a backlog. So backlog will put kind of a patient in a flat position so that the breast fall is less and the exaggeration of that fold can be avoided. Secondly, if the tumor is an upper quadrant, say, an early stage disease, then probably we can nicely avoid that breast inframembrane fold so that the dose there is relatively less and the chances of getting reaction will be less. But of course, we cannot really compromise on the volume of high risk kind of a volume getting into unnecessarily into making that fold cold and then underdosing the tumor area. So that should not be the thing. Axillary fold obviously can be well avoided by giving proper position and simulation. Head and neck, of course, when we have a node which is a bulky node coming close to skin, we really cannot do anything there. Of course, we can use a conformal planning, but still skin will be very closer to that node. But otherwise, in general, conformal planning will reduce the skin dose and will reduce the subsequent radiation dermatitis. Hotspot, nowadays skin will not receive any hotspot when we have a conformal planning. Alternate fractionation we use, but the alternate fractionation impact will be on the mucosa more than on the skin because mostly these are mucosal malignancies. So the mucosa will get higher dose of fraction, but the skin will still get a conventional dose of fraction because of any alternate fractionation.
So, before we conclude, I would like to ask Dr. Kamal sir to give us something that they do differently than what has been described in the literature, what has been described in the textbook, and what your colleagues or your seniors, your juniors are doing. Anything specific that you do differently?
Yes, I mean, the one thing which I am still missing is which I do is cut open the mask. Wherever there is going to be grade 3, you are expecting them. Get advantage of skin sparing of mega voltage therapy. Cut open the mask from that part without losing on the patient immobilization. It will help you a lot. Second thing, maintain nutrition. So we at in our hospital we always have weekly weight chart. Anywhere crossing beyond 5% is marked red. Patient has to be reviewed more often than usual. These two things have helped us a lot in controlling all these things. And even the supportive care which we give, the local therapies, steroids, NSAID, they are being useful, but their benefit is limited as compared to these two interventions. Weight is the major thing which I find in head and neck, and caring for the folds. I, I think this is all what we are caring for in our hospital.
Thank you, sir. Dr. Revti, any word of wisdom from Tata Memorial Hospital? Anything different that you do?
I wouldn't say different, you've been here. But I would say that any patient reaching grade 3 should be seen as a failure of the treating radiation oncologist, and it has to be taken very seriously. If any patient reaches grade 3, the plan has to be, you have to go back, review the plan. Why did it happen? You have to go back, review the CBCT. Was there anything which was missed? Instead of blaming, patient did not listen. Yeah, grade 2 to hota hi hai. That the mindset is not to be encouraged at all, especially in trainees. So radiation dermatitis in the present day can be very well prevented, and it completely depends on counseling, your pre-planning, your folds and your dose control and your plan, how is it? And as I said, anything going beyond grade 2 has to be taken extremely seriously and has to be audited. So that's more of a quality assurance thing. So once you do that, I'm pretty sure you'll start seeing less and less of skin reactions.
Very well summarized. I think let us conclude here. Anything from the panelists? Anything else anyone wants to add? So I would like to thank my panelists for having such a wonderful discussion on radiation dermatitis, and I would like to thank the team also for giving us this opportunity. Thank you.